Good evening, and welcome to the 6th COVID-19 webinar organized and hosted by Emmanuel Chapel, titled State of Health, Epidemic Outbreaks, Present and Future, which is following in the footsteps of 5 other sessions which have been robust in the discussions of topical issues around COVID-19 in Nigeria. This webinar focuses on the incident management of COVID-19 by the federal government, as well as a discussion on other epidemics that we must watch. The adage, health is wealth, cannot ring more true than it does today around the world, as COVID-19 cases are now topping 5 million, with 333,000 deaths, and the global economy brought to its knees. Here at home, earlier this week, the Presidential Task Force on COVID-19 ordered a maintenance of the status quo on the modified lockdown that commenced 2 weeks ago. While this allows for more movement, which is necessary for the economic survival for a vast number of the Nigerian population, it leaves unanswered questions as to the adequacy of our healthcare system to deal with a clear growing number of COVID-19 patients, the possibility of a surge in contagion, coping with existing epidemics amongst us, and a huge number of non-communicable diseases, which now seem to be getting less treatment and attention than before. Let us set the scene of the Nigerian healthcare system. Fact is that Nigeria has one of the most poorly funded health systems in the world, limiting both quantity and quality of health services across the country. May I have the first slide, please? Our total health expenditure last reported was about $70, and I'll use dollars at the moment just because of the, obviously the change in the valuation of our currency at the moment. $70 per capita, which is roughly just about 3.5% of our GDP. Out of which government spending, federal, states, and local contribution is about just 30% of that, and the rest coming from private out-of-pocket spending mostly. Health insurance coverage is still low, with less than 6 million people covered. And this means that, of course, on the supply side, there are some sort of specific indicators that we are watching. Nigeria has 0.9 hospital beds per 1,000 population, which amounts to a shortfall of over 375,000 beds. The workforce per 1,000 is also 0.38 for doctors, amounting to a shortfall of nearly 1,000 doctors. Slide 1, please. And 1.5 for nurses, amounting to a shortfall of about 300,000 nurses. On the critical care side, we have only about 400 ICU, intensive care unit beds, with less than 500 ventilators and about 200 anesthetists, critical care specialists, which puts our ratio of critical care to be about 1 to 300,000 people. Slide 2. Can we move on to slide 2, please? According to a PwC survey, more than 90% of respondents found healthcare in Nigeria to be of low quality as a result of the state of healthcare infrastructure and service outcomes. Against this backdrop, Nigeria is estimated to have around 10% of the world's total burden of disease due to its large population and its high level of communicable and non-communicable diseases, now known as the double burden of disease. Slide 3, please. In recent times, Nigeria has also had to face up to an increasing trend of epidemics: Ebola, yellow fever, cholera, Lassa fever, and now COVID-19. This can now be described as our triple burden of disease. Yeah, okay, that's slide 3. And we are now in danger of desecrating our other already fragile health system. I think you can see on this slide, particularly over the last 5 years, particularly 2018, when we had a significant cholera outbreak. And then, of course, in 2019, where we saw Lassa fever begin to pick up. And of course, these are all before COVID-19 came calling. Next slide, please, slide 4. In comes COVID-19. And WHO estimates that nearly 250 million people across Africa will be infected over the next year, with 190,000 deaths. With current infected numbers about 100,000 and deaths about 3,000, it appears Africa is still moving up the curve, with Nigeria being particularly at risk due to its large population. All of this comes with the warning from UNICEF that the disruption to health services and food security caused by the pandemic could also cause about almost 1.2 million children to die in the next 6 months. Primary healthcare is the front line of healthcare in all countries, including Nigeria, and it coordinates the prevention of diseases, management of chronic conditions, family planning, and treatment of illness. To invigorate the health system, the Buhari administration created a strategy to improve infrastructure by revitalizing 10,000 primary healthcare centers across the country to develop infrastructure and service delivery in every state. Also, in 2018, the Basic Healthcare Provision Fund was created to increase the funding of both primary healthcare and health insurance. Whilst we haven't seen that much yet of those initiatives, we are even now currently seeing a new scenario, which according to the Honourable Minister of Health, is showing that there has been a 50% reduction in the effective utilization of services because of lockdowns and the fear of being infected in hospitals. Private health providers, which are said to provide about 50% of health services in Nigeria, seem not to have been pulled in to join the public sector fight against COVID-19, as private labs, which have the capacity, have not yet been fully accredited to support the increase in testing, and private clinics and hospitals have not yet been fully trained and supported to increase the ability to treat even the mild cases. The voice behind the music of ending lockdowns we hear is asking many questions. How should I carry on with life in this new world of living with a highly infectious and dangerous virus? What should be done about containing the spread of COVID-19 as we get back to normal living? What do we do about the other epidemics which we have that appear forgotten? And more importantly, how do I get tested quickly so that I am not denied care for COVID-19 or indeed for any other ailment? My name is Fola Laye. I am founder and CEO of Health Markets Africa, and I will be your moderator for this evening. Good evening. I'd like to, at this stage now, start by introducing our most distinguished panel. It is my singular honor to introduce our distinguished panel this evening and to start by thanking them for taking time out of their busy work at the front lines of healthcare services around Nigeria to be here. Good evening, sirs. And may I start by introducing our Honourable Minister of State for Health, Senator Dr. Nimbe Mamora.
Thank you very much, Fola.
Senator Mamora, after a stint of about 20 years practicing as a medical doctor, went into politics, rising quickly, giving his knowledge, integrity, and respect to being elected into the Lagos State House of Assembly, where he was subsequently elected Speaker. He was elected into the Senate of the Federal Republic of Nigeria in 2003 and re-elected in 2007 for another 4 years. While in Senate, he served in various capacities, including Senate Deputy Minority Leader, Chairman Senate Committee on Ethics, Code of Conduct, Public Petitions, Member Senate Committee on Health. He sponsored the National Tobacco Control Bill, amongst others. He also served as a member of the ECOWAS Parliament while in the Senate. He was appointed by President Muhammadu Buhari as MD CEO of the National Inland Waterways Authority in October 2018, and held the position until his present appointment as Minister of State in Health in August 2019. Senator Mamora has received various awards and recognitions, including Distinguished Alumnus Award for Outstanding Public Service by Obafemi Awolowo Alumni Association, and admission to the National Roll of the Nigerian Medical Association. You're welcome, sir. Dr. Chike Ihekweazu, the Director General of Nigerian Center for Disease Control. Good evening, Dr. Chike, and welcome.
Good evening.
Dr. Chike was until January 2018 the acting director of the Regional Center for Disease Control for West Africa. He trained as an infectious disease epidemiologist and has over 20 years experience working in senior public health and leadership positions in several national public health institutes, including the South African National Institute for Communicable Diseases, the UK's Health Protection Agency, and Germany's Robert Koch Institute. Dr. Chike has led several short-term engagements for WHO, mainly in response to major infectious disease outbreaks around the world. He is a graduate of the College of Medicine, University of Nigeria, and has a master's in public health from the Heinrich Heine University, Düsseldorf, Germany. And in 2003, he was awarded a fellowship for the European Program for Intervention Epidemiology Training, and subsequently completed his public health specialization in the UK. You're welcome. I'd like to introduce next Dr. Faisal Shuaib, who is Executive Director, CEO of the National Primary Healthcare Development Agency, NPHCDA. Good evening, sir.
Good evening.
Dr. Shuaib. Thank you. Dr. Shuaib holds a medical degree from the famous Ahmadu Bello University, Zaria, as well as a Doctor of Public Health degree from the University of Alabama in Birmingham, USA, where he graduated with distinction. Prior to his appointment by President Buhari in January 2017, he was a senior program officer at the Bill and Melinda Gates Foundation in Seattle, USA, and was charged with the responsibility of developing and implementing strategies on polio outbreak response activities in Africa. Dr. Shuaib served as the incident manager head of the Nigerian Ebola Emergency Operations Center during the July to October 2014 outbreak of the Ebola virus disease. In this position, he coordinated a team of over 1,000 health workers and volunteers in the country's response to the outbreak. In addition to serving as a senior technical advisor to the Minister of State for Health on immunization and polio eradication, he was also the Chief Operations Officer, Deputy Incident Manager of the National Polio Emergency Operations Center. Dr. Shuaib's career also includes experience working with the WHO, Ministry of Health of Nigeria, University of Alabama in Birmingham, and he has co-authored a number of scientific journals. Thank you, sir, for being here. And finally, last but not the least, I'd like to introduce Professor Kofo Ogunyakin, an echocardiographer and cardiologist. Professor Kofo is Chief Medical Director, First Cardiology Consultants, and has been and still is Principal Investigator, World Alliance of Societies of Echocardiography Study in Africa. Also the African representative on the American Society of Echocardiography, International Relations Committee, and editorial board member, Case Journal. He was at a time fellow in Advanced Echocardiography, Tufts University, New England Medical Center, Boston, Massachusetts, fellow in cardiology, UCLA School of Medicine, Los Angeles, California, fellow in cardiology at SUNY Stony Brook Program, Nassau County in New York. He has the following board certifications and diplomas: Diplomate, Royal College of Physicians of the United Kingdom, American Board of Internal Medicine, Cardiovascular Disease Specialty, Diplomate, American Society of Echocardiography. His academic career includes being an assistant professor of medicine at the Northwestern University Division of Cardiology, Chicago, as well as being assistant professor of medicine, Queen's University in Kingston, Ontario, and assistant professor of medicine, Columbia University in New York. Welcome, sir. So at this stage, I'd like let's kick off the conversation. We will start obviously by having our own Q&A, and then obviously we'll invite questions from the audience. I would like to ask by asking each of the panelists a general question, and also to give an opening statement if you choose to. And it goes, given the backdrop of the severe resource constraints of the Nigerian healthcare system, how prepared are we for our climb up the curve of this COVID-19 pandemic? I would like the Honourable Minister to start, followed by Dr. Chike, and then by Dr. Shuaib, and then by Professor Ogunyakin. Honourable Minister, sir.
I think the first thing to say is to give kudos to organizers of this webinar, particularly to my friend and brother, Koyi Ajayi, Professor. And through him, to your good self, Fola, and all others involved in this. And of course, thank all the panelists in this webinar. Well, it's been a very trying period for not just Nigerians, but I think for humanity. And because of this COVID-19 pandemic. And in our own situation here in Nigeria, we have been doing the best we can in the circumstance because no nation was ready for this, including Nigeria. We were not ready at all. So, but we needed to do what we had to do from the beginning. And up to this point in time, it's the whole response activities is what you can call work in progress. So we're not there yet, but we'll continue to put in the best of our efforts and hoping that with such efforts, we'll be able to contain and manage COVID-19 so that together we can defeat COVID-19 pandemic. Thank you.
Thank you, sir. Dr. Chike.
Thank you, and thankful. Firstly, really to say it's a real honor to be part of this very distinguished panel. So thank you very much for inviting me, and good evening. I think to start with, firstly, to paint the picture of where we are. We now have just over 7,000 confirmed cases, having tested over just over 40,000 cases, 40,000 people in Nigeria. And this new virus has spread across the country. Every state except 2 have confirmed cases. The epicenter remains in Lagos, where we have about half of all the confirmed cases in Nigeria, but increasing numbers in Kano, FCT, Borno, Jigawa, Yobe, and many states in the kind of towards the north central, northeast. I won't go into too much detail because a lot of the information on the outbreak scenario is online, and everyone here, and probably most people attending, are well aware of the numbers. Our epidemic curve is still going upwards, so we're still in an upward trajectory in terms of the distribution and evolution of cases in Nigeria. Like the Honourable Minister rightly said, our response is work in progress. I often try and use the phrase that the best time to plant a tree was 60 years ago, or maybe more. The next best time is now. In certain aspects, we're paying a price for not taking certain aspects of our national development as seriously as we should have. over the last 60 years. But having said that, we are confronted with a new virus. And, I remember very early in my career when the HIV virus emerged, which has now infected more than 50 million people, or more than 40 million people, and continues to do a lot of harm. I remember the anxiety that it elicited in our population. And I remember how long it took at the time to get to any form of diagnosis, to get to treatment. Antiretrovirals came, I think, 15 years later. We still don't have a vaccine. But I also remember some of the very tragic stories, the anxiety that led us into believing people offering all sorts of cures around. I remember very clearly the Abalaka story and how many Nigerians went to be treated, quote unquote, by him. I remember the hesitancy of many global leaders when antiretrovirals emerged and how that ended up defining their political careers. So, that's the story of one virus. And then the story of another virus, the Ebola virus, and how really the response to that outbreak in Nigeria really was one of the highlights of our public health history. And my brother Faisal, who is going to speak after me, led that response in Nigeria, a very robust response, building off what we'd built up for the polio response at the time, which he very ably led to deal with the Ebola outbreak. But tragically, after that outbreak, after the response he led on 2014, by the time I got into this office in 2016, almost nothing was left of the response. The room in which they led that response in Lagos was a dark imagery of what it was. We didn't have a single national reference lab. The only EOCs, the EOC went back to polio, and we had no national public health EOC. We had no web-based surveillance system. We had no molecular lab within the public sector in Nigeria. So it was in 2016 that we started building slowly what we have now. And of course, we struggled for money, struggled for cash, struggled for resources, and built up the public health infrastructure as limited as it is, on which we have now based our response. And so based on that few years of building, we were confronted with a new virus that had spread globally. We saw countries that we had looked up to for years as role models struggle in responding. And there was nowhere to run for any of us. We'd seen this very often with Lassa, but with cholera, but maybe because of the socioeconomic strata of the people most affected by these viruses. Many of us thought, okay, this is, it won't affect us. So when we were confronted with this new virus that primarily infected the elite in Nigeria, and now it's moved on to the rest of society, we all realized, listen, maybe we should have built our health security infrastructure all these years. Maybe we should have built all these molecular labs that would have led us to be in a lot more robust position to respond. But having said that, over the last few weeks, with the support from government, from private sector, from the UN bodies, and really everyone has come together across health parastatals with the leadership of the ministry. There has never been a time where people have come together in solidarity as much to slowly build up what you're seeing at the moment. And as much as there's some frustration among Nigerians about the speed, sometimes when you're building, you don't see the success of the building until it kind of emerges. And, in between all this work, there's a lot of hard work that has gone in. Everyone is working hard across the sectors to make sure that we now are able to mount a robust response. But critically, and I'll end on this, is really, as we're building, my eyes are very much on the future. And I think that's what the Honourable Minister really has asked us to do, that in whatever we're doing now, we must never find ourselves in this type of situation in the future. We must now invest in our primary healthcare infrastructure. We must invest in our health security infrastructure, in our laboratory infrastructure, in a platform approach, and not just focusing on one disease or the other, or one small problem or the other, but make sure we build back better for the future. And that's collectively what I think most people on this call are working very hard to do in the public sector, to make sure that we build the institutions as we fight the virus that will help us get out of this situation, but help us be really stronger for any similar challenge in the future. So I'll pause here for now and let the other panelists have a go, and I'll be open to questions later in the presentation. Thank you.
Thank you very much, Dr. Chike. Dr. Faisal Shuaib, over to you, sir.
Yeah, thank you, Fola. I want to really appreciate Professor Ogunyakin for this opportunity to participate in this very impressive panel. It gives me great pleasure. It's an honor and a privilege to be on the same panel with my boss, the Honourable Minister of State for Health, my brother, Dr. Chike, whom I stand shoulder to shoulder with and applaud his outstanding effort in trying to get or commend Professor Kofo Ogunyakin for such an incredible career. Really, we are very clear that this outbreak was an outbreak that no country was prepared for. And it is an outbreak that will register in our memories as one of the darkest times in human history. It is an outbreak that has caused such tragic loss of lives. It has turned our world upside down. In our efforts to fight this pandemic, we find that it has negatively affected our economies. It has affected billions of people and has literally stopped a lot of economies in their tracks. This is a crisis like no other. And what we do know is that there's a lot of uncertainty in terms of how it's going to pan out. But what we do know is that it will require global solidarity. It will require uncommon resolve. It will require a coordinated approach to make sure that we flatten the curve. I want to register some of the challenges that we face in the health sector. Yes, in the past, we've been able to fight different epidemics, different outbreaks. The NCDC has done so well in the last few years in its efforts to curb Lassa fever, cholera, a number of vaccine preventable diseases where we've worked with the teams at NCDC, MPHCD and NCDC, working with Federal Ministry of Health staffers to really contain different outbreaks. But this outbreak is completely different from all the previous outbreaks. One thing that we're clear about in our minds is that we have to work together. Our priorities must be first to protect lives, secondly, to protect livelihoods, and thirdly, to chart and plan a sustainable recovery plan out of where we are currently. So I'm very, very happy that we have this opportunity to discuss as panelists and have the opportunity also to hear from people who have really signed up to listen to this discussion. So thank you very much for having us.
Thank you, sir. Professor Kofo, please.
Good evening, everybody, and thank you for the privilege of being part of this very, very important discussion. And I want to, I'm an academician, so we have to start with a disclaimer. And I want to state the three different vantage points that I hold here, so that the comments I make And the way I look at this, which as you said is a little different, can be put in perspective. So first, I'm a clinician scientist and learning real time with the rest of the world about this terrible disease that humankind had never seen before November of last year. Finding out how devastating it is, how it does not conform with any of our previously held beliefs about what needs to be done, how we can get ourselves out of it, and the steps and all that we need to take. And in that process, watch in real time the consequences to societies of ineffectual strategies. As we can see in the Lombardy region, who finally, in Italy, they finally woke up after 16% of their healthcare workers died in the first wave because people did not really understand the gravity of this and were looking at government do this, government do that. We saw what happens when a country like Germany embraces this head on and do a lot of things to get every single member of their society involved in the war and how they can reduce their death rate to levels that are uncharacteristic. And you can watch the tragedy that is unfolding in Brazil right now when you have another place where people just believe it's none of my business, I go about my business. So that knowledge enables me to see what we are doing here, and it fills me with trepidation. And certainly the answer to the simple question you want me to answer is how prepared is we're not prepared yet. But my second vantage point is as an advanced critical care specialist. And I operate and run a center that has resources that match those of any elite medical centers anywhere around the world. And we are getting to see the worst of this disease in its most terrible kind, where it is gut-wrenching and it is emotionally draining to see that you do everything, apply every technology, including taking over the human lungs, and still relentlessly have this disease claw every inch of it back painfully. I do not wish for the people who don't have my job to ever get to see this level. Which then leads me to the third perspective as a Nigerian who can see the wave of what is coming. And I watch the news and hear people think this is a hoax and they have so many things they want to do and all of that. And everybody is pointing at this person hasn't done this, this person hasn't done. We are in an existential war, a war we did not choose at a time that is not convenient for us, with resources that we would have rather we had that we don't have, but we are not going to capitulate. That is not what the indomitable Nigerian spirit is all about. So my perspective in all of this is that the medical part of it is actually straightforward. This is a disease of three parts. There is a mild disease, there is moderate disease and severe disease. And if we organize our system so that all the mild disease never progress to moderate, and we organize the moderate so that they never get to severe, we will save a lot of lives. But every single Nigerian has to see themselves as a soldier in this war. And if what everybody will do is just wear their mask, prevent others from catching the disease from them, and stay at home or keep themselves isolated when they don't feel well for just 7 days, they will be contributing towards the war. Then medical practitioners everywhere, including public and private, people are going to see these patients, whether they like it or not. So those who are not planning for it because they do not think they have a designation to be taking care of it, they are setting themselves up from when this case comes to them. They will wipe out their staff, take it to their homes, and cause the tragedy that we're trying to avoid. So everybody who has any experience in healthcare provision must figure out how to stay alive, how to protect themselves, and teach others about how to do that at this time so that we can move forward. Then thirdly, the members of the civil society. Look at what happened in New York. Look at what happened in California. They changed their laws. New York is a very regulatory state. They waived the laws about state licensing for people to come and work because they needed help. So you could bring a medical license from anywhere and you'll be allowed. They graduated students in their 4th year so that they could come and contribute to the workforce. They retrained or they drafted dentists and radiologists and all those other people to come and help out. So we do not have the luxury of just sitting and saying we want NCDC to do this, want federal government to do this and all of that. We've got to actually look at this and summon our indomitable spirit so that we can collectively do something to block this terrible tragedy that is heading our way.
Thank you very much, Professor Kofo. Thank you. So I'd like to, just before our next question, conduct a quick poll. Can we have the question, please? So just a quick one. I'd like to sort of just get a sense check of our participants, particularly those who are here in Nigeria, that if you feel unwell, even if it's non-COVID-19 related, where would you seek healthcare from? Would you be from going to the clinic or hospital, or from staying home and self-medicating? Okay, great. So can we have the answers straight away, please? Okay, so it seems almost 50-50, but it does seem that it's still a little bit skewed to people saying they would stay home and self-medicate. Thank you. So on that note, I'd like to ask the question to the Honourable Minister, sir. What is the federal government doing to help to support a secure and affordable supply chain for PPE, the protection for frontline healthcare workers for Nigeria, just as we have read that other governments have had to do for their own countries? It's become such a part of the national response of most countries to secure PPE, and I don't know what we are doing. How can our frontline of workers really feel assured and feel that they are being adequately protected and their lives are also being safeguarded whilst they are on the front line of fighting COVID? And what measures should be taken by hospitals, particularly in the case of the federal government, the teaching hospitals and the federal medical centers, to assure the public that they are safe to come in for non-COVID treatment? Because that's a key issue right now, where a lot of public really don't feel safe to come in, as well as obviously the healthcare workers themselves feeling safe to treat. Please, sir.
Yes, thank you, Fola. Now, the truth is that we have a duty to ensure that our frontline workers especially, in fact, all health workers at this time, but the frontline workers especially, we have a duty to ensure that they are safe. They need to be alive, they need to be well for them to take care of patients, whether they are COVID patients or non-COVID patients. So that's a duty for us. And in that regard, I do know that aside the NCDC giving out some PPEs to various hospitals, and particularly the centers, that is treatment centers or isolation centers, but particularly the treatment centers, because these PPEs that we talk about, they are in different grades. What a health worker within the treatment center, and particularly ICU, needs will be different from what somebody in isolation center may need, or somebody who is taking care of routine patients. So, but the basic thing is that we have a duty, which to a large extent, we are doing that. So NCDC provides PPEs. The Federal Ministry of Health also does. And of course, we have donations from various groups. You know, we have from China, we have from EU, we have from COVID. So many individuals, so many groups, so many companies assisting us in this regard, and which we very much appreciate. In fact, we know that some religious bodies, some NGOs, they're also contributing in this regard, because it's a basic thing. And when you talk of these PPEs, even the gloves, the mask, the face shield, these are part of the PPEs we are talking about. So we are ensuring that this is available as much as possible. And of course, we are conscious of the fact that we don't want a situation where the hunter becomes the hunted. That is, the healthcare workers themselves, they feel unsafe, or they are down with the disease, you know, or any, you know, finding themselves in a situation that is not palatable. So very conscious of that. Now, you also asked the question that what are we doing? Yes, in fact, the approach is to tell our health workers, particularly frontline workers, to see every patient as a potential COVID case, so that you take all the necessary precautions. So you don't take anything, you know, for granted. Take that is the starting point. Every case that you see at this point in time, just take it that it's a COVID-19 case until proved otherwise. And that is the first thing. So once you have that kind of thing in mind, then it will guide you, it will increase your level of consciousness and the care that you have to take. And it's a two-way thing. You have a situation where the patients themselves are scared going into the hospitals because the fear of picking up infection. You also have a situation where the caregiver, whether as a doctor or as a nurse or as a pharmacist or whatever, is also anxious. Oh, am I sure that this patient is not COVID-19 case? So these are the issues which we try to bring on board, and of course make this, make that consciousness to sink, into the caregivers.
Thank you very much, sir. Thank you. And just before the next question, can we have the second poll, please? Okay, this is how easy do you think it is to take a COVID-19 test? I'm not sure if it reads fully, but the question is, how easy do you think it is to take a COVID-19 test? Do you think it's somewhat easy, that can be done with results in a matter of hours, or not so easy, it takes days and it's difficult to obtain results? Okay, so we'll just wait for the answers real quickly. Okay, so it seems overwhelmingly that voters feel it is not easy, it takes days and difficult to obtain results, 85%. Okay, thank you. So I have a few questions for Dr. Chike. just before we go into COVID itself, I'd like to first of all just sort of broaden the discussion, if I may, or the questions. First of all, I mean, I know that, of course, the work of NCDC itself is a relatively young institution. And of course, your own role there, and given what you've had to already deal with, you know, in the few years of it, you know, the fact that we've had these epidemics now of cholera, of yellow fever, of Lassa, and of course now we're dealing with COVID. So my first question is, have we really now taken the step to redefine our universal health coverage strategy to include, you know, public health and the care of disease epidemics and pandemics in this way? Is it now, you know, really institutionalized? And has NCDC even been included in what I might call this Basic Healthcare Provision Fund, the BHCPF framework, which is rolling out funding as well as, you know, services for healthcare, which is the key way of increasing our services around the country? What role would you say NCDC is playing, you know, in that regard? After that, I'd then like you to tackle the issue of testing. And testing, really, the fact that you have come out with a very laudable remarks over the last few days of increasing testing significantly and wanting to test up to 2 million Nigerians over the next 3 months. I also understand, and from your opening remarks, that, you know, the private sector is being integrated into this testing. But still, this means that we have to go from testing 1,000, 1,500 a day to something like 20,000 a day. Do we have the capacity, even as we join up, you know, all parts of, you know, of the testing capacity, to really be able to achieve this? And then perhaps my, you know, last question along these lines would be, you know, where is the real issue or bottleneck when it comes to testing? We have a couple of states, Kogi and Cross River, who say they have no cases, but it looks as if they are not testing at all. What really is the key issue there when it comes to testing widespread across the country? Over to you, Dr. Chike. Thank you.
Thanks, Fola. I have really got a number of questions, but all important ones, and we'll take them on. I think the first one around universal healthcare access and things like that is to, I think across both our public and health and clinical care environment, we haven't really given diagnostics the focus it deserves for many, many years. Many of us have been trained to, as if diagnostics really don't matter. You know, we're socialized to think that our clinical skills are enough, that every fever is malaria until proven otherwise, and things like that. And so as the world moved forward in getting better diagnosis and therefore making care much more specific to the virus or bacteria or parasite that was causing illness, we focused more on broad spectrum antibiotics, you know, and just finding a way to go around the problem rather than confront the problem. Our diagnostic labs, both in the private and public sectors, have remained in the dark ages for many years. If you go into any laboratory in many of our public sector facilities, it's the most underdeveloped in most hospitals in the tertiary sector. If you go to the imaging department, you see modern equipment. If you go to most departments, but if you go to the microbiology lab in most university teaching hospitals in Nigeria, you'll be surprised. Most of the infrastructure there is from the 50s and 60s. In the private sector, until recently, where we had a few chains evolve, most private sector labs were one-man businesses in one small room somewhere in the corner of most cities. And this has been our reality. And I think as we walk through the challenges we have, we must always remember that we are living in the country we are living in, not the one we wish to be living in. So that we must confront these challenges one after the other, take them on, and be very razor sharp focused on making it better. But if we don't accept where we are, we can never make it better. So this is really where we are in terms of our diagnostics. And so I think this is a wake-up call for all of us to really start focusing not just on COVID, but on basic fever diagnostics. You know, a patient comes to the hospital, what is causing that fever? Is it Lassa fever? Is it yellow fever? Is it malaria? Is it COVID? It could be any of these. But right now, we don't try to find out. We give you a malaria treatment. If it doesn't work, we give you broad spectrum antibiotics. If it doesn't work, and then 3 weeks down the line, we start looking for a lab that can make that diagnosis. And until we reprioritize the lab in terms of our diagnostics and our clinical workup, then we will start getting the answers to these questions. And this is really what I hope to come out of this. One of the things I hope to come out of this more broadly. To your second question on the basic healthcare provision fund, there are ongoing discussions around this. In the short term, half of the emergency funds, half of the 5% towards public emergency treatment were dedicated to public health emergencies so far. But you know, a lot of this is work in progress. It's not yet fully agreed to by everyone. But one thing I don't think anyone can struggle with or quarrel with now is that we need long-term sustainable funding for health security. This is not something you look for money when you have a problem. If we wait for that point, we will always be in this situation where we're always scratching around for funds. So the Basic Healthcare Provision Fund provides a once-in-a-lifetime opportunity to provide long-term sustainable funding for health security. If we don't take this challenge, if we don't take up this opportunity as a country, generations ahead of us will never forgive us. So this has really been my doctrine to all of us, working hard to make sure that this fund works for Nigerians now and into the future. On the third point, third question around testing, Fola, I know this has really been a difficult one to explain to people. Because when most people think about a test, they think about, you know, a rapid diagnostic test for malaria or for HIV, or a pregnancy test that takes a few seconds. You put whatever body fluid and you have yes, no answer out of this. You know, real-time PCR is an arduous 6-7 hour process of careful calibration of fluids, diluting it, putting the sample into it, rediluting. So there are 3 stages, and then eventually putting it into a PCR machine, all under biosafety conditions. So there were only 5 labs 3 months ago that had the capacity to do this across the country, and that's where we started from. And we've kind of worked to re-engineer a series of labs across the country and rapidly train them. Sometimes we've had problems, like in Kano, if you remember, we were pushed so hard to open labs. We worked, we pushed, and then they had to shut down for a week again because there are biosafety issues and some people got infected in the lab. So we then slowed down and said, listen, we have to be safe despite the pressure to progress. So it's a very arduous process. But in addition to that, it's not just the testing in the lab. You know, the right sample has to be collected, the form has to accompany it, it then has to be packaged in something we call a virus transport media, sent to the lab. So there's a whole logistics before even anyone talks about the actual testing. So if you think about, if everything goes well, you know, you need 24 hours. In most cases, you need 48 to 72 hours to get a result as it is. But that's the reality as it is. But there's good news around the corner. The things that we've been working on with our global partners to convert some of the TB testing equipment known as GeneXpert to work for COVID, we've been working very hard, but there's a global supply chain problem. So this hasn't been about money, because we've actually had the resources to do this. It's just that we couldn't get our hands on any of the reagents. But now we've got our first date of delivery, 27th of May, for the first set of GeneXpert reagents to come in. And we have a big UN delivery also coming in. So there is light at the end of the tunnel. We will be able to scale testing. I always say for testing, we're solving for three things. We're solving for proximity of the labs to where the test samples are being collected. We're solving for scale. So in Lagos, it's not about proximity, it's about throughput. We need some high throughput machines that can enable a lot more tests be done within a shorter period of time. So in places like Lagos and Kano, we're solving for throughput. And then thirdly, we're solving for sustainability. So whatever investments we're making now, we have to be sure that they carry us into the future. So I think to summarize on this testing issue, it's a complex process. It requires process engineering, something that is not always easy in the public sector to achieve, but we're working very hard on this across board. And like you rightly said, we're now bringing in the private sector. We first issued guidelines for private sector labs that can offer testing for public sector. So private sector labs that will be supplied public sector reagents to supply testing. And that's how we've commissioned the lab in Imo State, Anambra State, and Kaduna. All these are private sector labs working for the public sector. But the next step is to get private sector labs working completely independently for the private sector, where you can go in, pay for a test, just like you can pay for any other test. So that's the next set of guidance that will come out this weekend. And our role is not to regulate or accredit. Our role is really, this is a new virus, so we needed to make sure that we do the right thing. We've been under a lot of pressure, and I'm sure every governor will say the same thing, to offer people rapid diagnostic kits, tests. And I always ask them, very often I get a kit sent from a country. I ask them, is this kit being used in the country from which it is being sent to us? The answer is often no. So throughout Western Europe, throughout the US, throughout the rest of the Americas, everyone is using PCR, at least now. There's slowly becoming some validation data coming out for the RDTs, but none of these countries are using them now because they're not sensitive enough to give us the answers that we need. So as soon as one becomes commonly available and acceptable, we will move. But until then, we'll make the very best of what we have, convert the gene expert, convert some of the HIV testing capacity, and make the rest of our capacity work better. So yes, we're not where we want to be, but also, yes, we're working very hard to get better and assure Nigerians that we will get to where we need to. But testing, remember, is not going to solve all our problems. There's a lot of focus on diagnostics, and rightly so. But there are many other parts of the food chain that need to work. There are states in Nigeria now that have tested less than 10 samples since the beginning of the outbreak. And I think some of the attention of Nigeria should focus on those states while we work on developing the capacity to do the testing among the labs working with us. Thanks.
Thanks, Doctor. So if I now turn to Dr. Faisal Shuaib, and let's talk about the primary healthcare situation. We're talking about the fact that, yes, we are now beginning to live with epidemics. We're living with Lassa fever. We're living with yellow fever to some extent. And of course, we're living with COVID-19. How can the primary healthcare system really be expanded or extended to cover these infectious diseases in addition to all the other services that the system is meant to provide for? What's the way of really assuring again the population safety of being able to use the primary healthcare system? We know that women and children are particularly key users of the primary healthcare system, and they're not being or not feeling safe enough to come in. It's clearly one of the key issues that we are facing. So how can we, what are you thinking about as you think about, the vast network of primary healthcare around the country that can really help to safeguard in this way? Thanks.
Right, thank you for that question. First, we have to, as Nigerians, recognize the fact that our primary healthcare facilities are not anywhere near where we'd like them to be. Again, you clearly articulated it eloquently in your opening presentation, where we acknowledge that our primary healthcare centers are the way they are because of decades of poor investment in the health sector. But even particularly so, inadequate investment in primary healthcare centers. Over 70% of the populace live in rural areas where ordinarily the primary healthcare centers should be where they get quality primary healthcare services. But this has not been the case because we find that year in, year out, there isn't enough investment by states in primary healthcare. In the last few years, there's been a lot of confusion as to whether primary healthcare is really within the remit of the federal government, state government, or even the local government areas. In many states, it has been relegated to the local government areas that are perennially underfunded. So here you are, you have an LGA that can barely pay staff salaries, let alone have enough funds to take care of the infrastructure to hire human resources that will man these primary healthcare centers. So what this has resulted in is primary healthcare centers that do not provide good enough quality in terms of the services that they provide. At the National Primary Healthcare Development Agency, we have a mandate to support states and local government areas towards strengthening primary healthcare. We advocate, we provide policies in collaboration with the Federal Ministry of Health. But no matter the level of advocacy, no matter our passion and our dedication to ensuring that primary healthcare services improve, if the states do not commit funds to improving the infrastructure, if they do not commit funds to hiring the human resources that are required, if they do not provide the seed funds to make sure that the drugs are available at the primary healthcare centers, they are commodities, and there's adequate monitoring and supervision, there's adequate performance management of these primary healthcare centers, then there's a huge gap that has ultimately resulted in a weak primary healthcare system and a weak healthcare system. The primary healthcare systems are supposed to be the solid foundation of any healthcare system. In 2017, President Muhammadu Buhari launched the Primary Healthcare Revitalization Program. This revitalization program was visioned to ensure that at least in every political ward, there is one functional primary healthcare system, functional primary healthcare center in terms of the right infrastructure, the right utilities being there. There's electricity, there is water, there are drugs, there are commodities. You also have qualified, trained and retrained human resources in these functional primary healthcare centers that can provide primary healthcare centers to all Nigerians with compassion, with dignity and respect to the patients. But this has not happened consistently across the nation. In the last few years, we've been able to revitalize up to 4,000 primary healthcare centers. In a number of states, a number of LGAs, we find a situation where there is an inadequate understanding of revitalization. Sometimes the local government chairman will put a coat of paint on a dilapidated structure or just renovate the infrastructure and say, hey, come see my primary healthcare center, I have revitalized it. Meanwhile, they leave out the very important element of the human resources that should be there, the full complement of human resources, the midwives, the nurses, the community health extension workers, the junior community health extension workers, and also the CHIPS agents that serve as the link between the primary healthcare center and the communities. So we're at a point where His Excellency, Mr. President, has now signed into law the Basic Healthcare Provision Fund that you mentioned earlier. And under the leadership of the Federal Ministry of Health, we're working together to sort of cross the I's and dot the T's, right? To cross the T's and dot the I's so that we're able to sustainably provide a framework that will deliver resources to the primary healthcare centers so that from national level, we can send funds directly to the primary healthcare centers and the primary healthcare managers, the officers in charge of the primary healthcare centers, can actually fix a roof that is leaking. They can paint the primary healthcare center, and they can, on a temporary basis, even recruit the kinds of human resources that they need for these services. Now, while we're doing all of this, we got hit smack in the face by the COVID-19 outbreak. Some 2-3 weeks after the index case of COVID-19, it became very clear that this outbreak had moved into the communities. And at the National Primary Healthcare Development Agency, we started working together with the NCDC, worked with the Federal Ministry of Health, worked with the National Health Insurance Scheme to get a better understanding of what will be required when community transmission actually becomes more evident. So together, we developed a comprehensive document that provided primary healthcare workers with clear guidelines around what to do if and when they are confronted with community transmission. We've gone through the process of doing a state level, and now we're cascading trainings all the way to the community level, across to the states, the local government areas, the community leaders. And we've been having conversations, we've been having discussions with traditional leaders, with religious leaders, with political leaders, with civil society organizations, faith-based organizations. These are the gatekeepers in our communities, to give them a correct understanding of what the outbreak is about, to also emphasize the need for correct information, to reduce discrimination, to reduce stigmatization around COVID-19. So what we're seeing now is a situation where we're building the capacity of primary healthcare workers to first have a very high index of suspicion so that they are very prepared. This helps tremendously towards case detection. They are very clear in their minds about if they have a patient in front of them that has the classical symptoms of COVID-19. They know that it is not their responsibility to try and manage. What they should do is isolate these patients and call the helpline, call the NCDC helpline, or call the local government disease surveillance and notification officer, or the state epidemiology, or even the state task force, and say, hey, we do have a patient that fits the symptomatology of COVID-19. But beyond that, we've also made sure that the primary healthcare workers have the capacity to recognize that they're also at risk. So they have to protect themselves, and by the same token, protect their patients by making sure that they are well kitted, right? That they have the personal protective equipment, they have the face masks, they have their gloves, they have sanitizers, they have the opportunity to wash their hands. All of these were building up over time, right? Focusing on where we have the greatest burden of disease. But working also with the traditional institution, with religious leaders, we are also making sure that community members have the types of information that they do need. So we are leveraging on the polio eradication structures, the human resources, the same people, the frontline workers who in the last 20 years have been in the forefront of the polio eradication fight and have taken us to a point where we're just a few weeks away from being declared polio free. These same health workers whose capacities have been built around interpersonal communication, whose capacities have been built around contact tracing, are involved with the NCDC on how to go house to house to do contact tracing. But beyond that, we're also using the volunteer community mobilizers who go from household to household, from community to community, to give the correct information about COVID-19. We're also using technology, frontline technology like Avada, right, to change and repurpose handheld devices that ordinarily will report on polio, report on cases of acute flaccid paralysis. Now they are reporting on any individual that has symptoms that are similar to those of COVID-19. And with that handheld device, they are able to quickly and instantaneously send messages to the central level. So all of this is bringing over 40,000 community-based mobilizers to the effort to make sure that it is no longer a national, Abuja-based effort, but an effort that is based on collaboration with community members, ensuring that COVID-19 outbreak response is no longer sort of their effort, but the effort of the communities. It is now community, it is now being community planned, community owned, and community driven.
Thank you. Thank you very much, Dr. Shuaib. That's a very comprehensive response. Thank you. Okay, one question for Professor Kofo, and then we can start to take our questions from our audience. Very quickly, Professor Kofo, I think we've already sort of begun that discussion with Dr. Chike about the role of the private sector and how the private providers can come into really join forces with the public system in terms of fighting COVID. So just as private labs are being brought in for testing, where would you say, where would private clinics, private hospitals be placed in coming in to fight, the battle for COVID? Your center, FCC, which is a private center, already is accredited and has already been treating patients, particularly in, along the lines of the critical care, as you said, for the most severe cases. I mean, based on what you've seen and what you know of the private sector, is there more capacity to do more? Do you have more capacity yourselves? And what's the cost? Because I guess that's another question people keep asking, that if we do want to sort of seek help or care in the private sector, what would it really cost us to do this? Thank you.
Okay. I don't think the question is whether private clinics should be playing a role. Is that I do not think that any clinic, public, government, have a choice in this matter. Really, we have done 40,000 tests. The population of Lagos is 20 million. So if this tackles only 1% of Lagosians, we will have 200,000. We do not have the luxury of saying this is a general hospital, this is a state hospital. And let's look at the precedents of other places that had to deal with this crisis. In New York, they shut down all conventional clinical activities. They had to bring the naval ship to come and take over what the normal activities, and the president invoked special laws that allowed them to. But it would not be fair in this environment if government just wants private clinics. You go retrofix your institution to make it safe. We'll come and inspect. We don't like where you put your air vent. We don't like where you put this thing. That is not the relationship that is needed here. The important thing here is to actually say, number one, in every institution, what do we have to do to make it safe for the healthcare workers at this location to be able to take care of COVID patients? And how can each of these centers be remodified such that a certain section can be carved out where the care of COVID patients can occur without mixing them with that of the general public? We did those things by ourselves, partly because before all of this, we were part of a special research program from Northwestern University, where I used to be, and Professor Babafemi Taiwo, where we were trying to grow an emergent pathogen a specialty center for West Africa and Africa here, and we sent people to America to train so that we know what we need to do to create this. But we did those things by ourselves. But we also are profiting from that and still work. And we have not abandoned our regular patients who are petrified to show up because they've heard that we take care of COVID. So it has been bad for business in terms of economic activity, because if the number of people who will visit your clinic plummets by more than 70%, it doesn't matter what you are able to bill for the people who come to you. But what I was saying in my opening statement is that it shouldn't get to where people need the type of help that I can provide. If we could organize our hospitals such that just being able to take care of mild disease, prevent the person who is vomiting from getting dehydrated and then knocking off their kidneys in the process, be able to make sure they take the right drugs to get their anticoagulant shots and all that, you will prevent the mild disease from becoming moderate disease, and they will leave the hospital, or they might even be able to go home. So we have to get every single one of the medical centers available in this country repurposed. And it might be that for each zone, we would say, okay, general hospital work, you can go to this particular hospital, but if you have COVID or we suspect you have COVID, you go there. And we now focus on energy to make those people safe. If that initiative is seen, then it's going to be a matter of private clinic themselves and saying, when the chips are down and the whole nation is going to war, what role did I play? But it's not going to be a matter of people say, I want to help, but they are being given all kinds of runaround. And that unfortunately has been, it appears that we have not recognized the scope of this problem. And that's why the way I look at this, I'm not looking at it in the micro way of the capacity we are going to need to build for the future. I'm looking at what we must do right now to be able to contain this, looking at the examples that other places around the world and the emergency adjustments they had to make to their rules and regulations in order to get the job done. After all, the Nightingale Hospital has now been disbanded, but they had to do it, and they amended different laws to make that happen. They confronted the peak of their crisis by getting prepared. That is the way I look at this right now.
Okay. Thank you, Prof. And you didn't speak to the issue of cost.
The cost, it is, okay. So it is expensive to take care of these patients. For example, if you have to have critical care, immediately, because it is not possible for any medical staff in intensive care to spend more than 6 hours in those suits that you see. When they are in those suits, you cannot drink, you can't eat, you can't even take a leak. So the experience from South Korea says the maximum any healthcare worker can stay in that state is 6 hours, which means that shifts that required 2 people before automatically required 6 to run the same shift. And then you have to make an arrangement for hazard pay, and that's just for a start. And then the protective equipment. So each person has to have protective equipment and have to do all of that. And then this disease, the tests that need to be done, they need to be done real time to ensure that things are not going south. So that if the breathing is not doing well, the blood gas has to be able to guide you to when you need to escalate from what you're doing to something else, etc., etc. So it is very expensive. But like I said, I am seeing the people by design. I'm seeing the people who are the worst of this, and it is not something that should be the focus of the plan, because if we do a good job, not many people, less than 1/2 of 1%, would reach the level of illness that would require the type of expertise that we have here. And anywhere in the world, those types of care would cost a lot.
Thank you very much, Professor. And so we have some time for questions from the audience, and maybe just, following up from Prof's question, I wanted to pose a question to Dr. Chike. And the question is that, can clinical diagnosis be used, to detect COVID-19 instead of a lab test, such that, as Professor Ogunyakin is saying, perhaps cases can be diagnosed earlier in hospital before they get so severe? So can a clinical diagnosis, is it something we can think about and let that protocol be shared to providers across the country?
I think Prof might have been a better person to actually answer that question, since he's the one among all of us that is actually dealing with patients. But the answer is twofold. Firstly, we do require a very so you can't make the diagnosis based on a clinical presentation on its own, but you need a high index of suspicion in order to suspect that people have this disease. But obviously, you can't make the final decision, the diagnosis, without a laboratory test, unfortunately. But we do need a high index of suspicion, and the fact that the clinical presentation of this disease is fairly variable. Many people, yes, we describe it as a respiratory illness, and most severe cases will present with respiratory distress, but many cases would present just with a fever or with very mild respiratory symptoms that would normally not even take you to a doctor, and sometimes just get progressively worse or spontaneously get better. And it's very difficult right now to predict who gets better or worse, apart from in those patients with obvious comorbidities that we've identified, especially, so the key risk factors at the moment are age, hypertension, diabetes, and a few others, but those are the critical ones. And with those, you can kind of say, okay, it's likely to be this, and you'll be more aggressive in your testing. But in a middle-aged, in a young person with a fever, it's very hard to say is this COVID-19 or not, just based on a clinical presentation. Maybe Prof might want to jump in there, but that's what our understanding is. And that's why we have to work very hard to make testing easier and more accessible to people.
All right, thank you. If we can just leave it there because of time, I wanted to ask the Honourable Minister a question that came in, that Nigerians living abroad who want to travel back at the moment are faced with a 14-day quarantine. Can it not be simplified by asking for a test to be done in the country of where they're embarking, and not be allowed to board if they don't have a negative test result? Could that not simplify things rather than having to be quarantined out here? Honourable Minister, sir.
Thank you very much, Fola. Just before going to that question, answer the question, let me just add to what Dr. Chike said. We should not forget that you even have a lot of people, majority of people not even showing symptoms. And so if they are not showing symptoms, it will be difficult to have a clinical diagnosis, So just to add to that, a large number of people may not even, they are asymptomatic. So there will be nothing for you to even work on to be able to make any clinical diagnosis. Now, having said that, yes, the issue of having Nigerians wanting to come to do tests in wherever they are, if we consider that option at the PTL at a point, but we discovered that quite a number of people were not even having it easy to get tested wherever they are. And besides, we had on a note that the cost of these tests in some of these countries is quite expensive. And some of the Nigerians might even want to, who just find it inconvenient for them to pay that cost. That's on one hand. On the other hand is that if you do a test today and you are declared negative, it doesn't mean that by tomorrow you cannot pick up the virus. So that is also a problem, you know. And again, even if as at the time you were taking the test, probably you were still in depending on the kind of test done, you are not even getting a confirmation that you're carrying the virus. So which means that by the time you get into the country, it might just be the time that you're beginning to show, or you're beginning to have a level that the virus can be confirmed in you as a patient. So these are some of the factors that well, we felt it would be proper for people to come around and then get quarantined and then be tested before the expiration of the quarantine period.
Thank you, sir. At this point, I'd like to start to wrap up. A fair number of questions from the audience are around the same issue, which is the issue that I'd like you, the panelists, to address in your closing statements, which is really about the fact that, you know, to the extent that COVID-19 is here to stay for a longer term, and to the extent that we may not get a vaccine as quickly as we would like, we have to, you know, we have to think really strongly about how to change behavior. And I think Professor Kofo spoke about that at the beginning. So I guess my question now to each of you is, what are each of your agencies doing? You know, what would you prescribe as, you know, really changing behavior for the long term? Because we know we've talked about mask wearing, hand washing, physical distancing. Some people are still questioning whether the masks can really do anything, whether they will get reinfected even after they've had, you know, one bout of COVID. So that's really where the concern lies now. If you could please speak to that as you wrap up. Honourable Minister, sir.
Well, once again, thank you, Fola. Now, yes, I also want to thank Professor Kofo. On a lighter note, I was wondering whether you know, a man answers Kofo. I thought it's a lady, but right now the issue is this: COVID-19 has been described, in terms of management, as all of government and all of society. So everybody has to get involved, and people must appreciate that you as an individual, you have the primary responsibility for your health. That's a basic thing. And they know that what you do to yourself will help a long way in even protecting others around you. So we have to continue to engage in advocacy and, of course, education. These are critical issues because as we speak now, there are people out there who are still living in denial, abusing us, saying that there's only like COVID is just a way to make money. You see some of these things, but you still have to do what you need to do. And that is quite unfortunate. Unfortunate because you have people who are taking their lives. And yet some people out there, they still don't believe, and they feel, they just decide to have their own, thinking. Of course, the issue of people not displaying the right attitude in terms of discipline. If you're talking of physical distancing, social distancing, you're talking of measures that have been put in place, what you call non-pharmaceutical measures, and people are failing or refusing to carry out these advisories and directives. I think that is not also fair enough. And of course, it's important for people to take that responsibility for their own health and for the good of all of us together. So these are some of the things that are very important, and we cannot be tired of putting this out to our people so that collectively we can win the battle. But before I just close my segment of this, let me seize the opportunity to say bravo to all health workers, and I mean all, from the cleaner to stretcher bearers to nurses to doctors to pharmacists, everybody, because everybody in the health community is putting his or her own life at stake, particularly at the frontline level. And of course, I cannot but also thank my colleagues there. Chike, NCDC, he's doing a marvelous job. It won't be perfect. None of us would be. But we must commend people for what they are doing. The same thing goes for Dr. Faisal in MPCD. He's doing a lot of work, and I know what he has put, the passion that he has put into all these things. And finally, Professor Kofo, thank you very much, because the perspective you have brought into it, and of course, even your opening remarks in terms of people getting to appreciate the reality and the severity of this COVID-19, which people out there, a lot of people out there just fail or refuse to appreciate. Thank you very much, Fola, and of course, through you, to my brother, Prof. Koyi, for this. I very much appreciate your own efforts. Thank you very much.
Thank you, sir. Dr. Shuaib, please. 1 minute.
Yeah, thank you very much, Fola, fellow panelists. After what the Honourable Minister of State has really articulated in a very eloquent way, I have nothing else to say, just to appreciate all of the efforts, thank the organizers, and really appreciate all that Nigerians are doing. These two shall come to pass. I believe that we will get over this hump. We just need to pull in the same direction, and I'm sure that we'll be successful. But this is really a unique opportunity in our lifetime to strengthen the health system. So thank you very much. I think the Honourable Minister of State has really said it all. Thank you.
Thank you. Dr. Chike, please.
Well, thanks, Fola. I'm really thankful for this opportunity. It's been great, especially listening to Professor Kofo and his perspective on things. One we don't hear often enough, and we have to amplify a lot. I think just to end on a human note, leaving home this morning, my children asked me, that when will we get back to normal? Like many other kids, they've been at home for weeks. They're lucky to be in a school where some level of homeschooling is possible. That's not a situation for most kids in Nigeria. So many of us are having to contend with a new reality with no end in sight, and it's hard. And I just want to say, it is hard, but we have to kind of keep at this. And really, what I took from Professor Kofo's comments are really how we think about everything we do, not just what the lab does or what surveillance does, but clinical practice will probably not be the same for many, many months. And by the time we get to the end of this, we may end up just staying where we are and not coming back. And I hope that some things will change forever. Our attitude to infection prevention and control, our attitude to hand washing at home. These are things that I hope will stay. There are other things that I hope we'll be able to do again. I hope we'll be able to hug each other again and share affection and things like that. So it's a long weekend for all of us. I wish everyone on this call, a good Salah celebration for those that are celebrating. For the rest of us to reflect on this new time and see how we can all adapt and come together as a country to get over this very difficult period. Thank you very much for having me. I deeply appreciate this, a real privilege being part of this panel.
Thank you. Thank you. Professor Kofo?
Thank you for the opportunity to be here. My closing remarks are going to be just two. One is, I'm the one that does not work for the government here. And that's why my message is actually to every Nigerian. Let us actually ask ourselves, what are we doing? And I think if we stop pointing fingers and we say, what are we doing? So anybody who is participating by not infecting other people with the virus, but infecting them with education about how to keep themselves safe, those people are contributing. But people who want to just protest and raid those are going to look at themselves and say, what did I do? So that's number one. Let us look inward and say, what are we doing to contribute in this nation's battle against this disease? The second is a more optimistic note. I have a feeling that there would be a uniquely Nigerian approach to answering this question eventually. We have a logistical challenge right now in the sense that we cannot do the tests that we need to do and get the results as quickly as we need to do them, but people are sick. And although there is no scientific proof that allows us to document what the alternative pathways would yield, if people who have fever, who have a cough, who have symptoms that suggest COVID, are kept in their home for 7 days and they are not allowed to go anywhere, and they are not able to spread this around, and they do the tests, if they get the test result on time, fine. But after 7 days, we know that people stop shedding this virus at a rate that is dangerous. We may end up solving this problem by just keeping people who have clinical suspicion because of exposure to somebody who has it. Keep them where they are safe from contaminating others. And we would take care of a lot more people than the tests and the test results we have. And yes, our data may not look fantastic to the rest of the scientific world. We will save Nigerian lives. And that would be a uniquely Nigerian situation. We did something like that during Ebola. I was in a driver's seat because of my friend, the former commissioner for Lagos State. They paid people to show up if they think that they have been exposed to Ebola, knowing fully well that many people who did not get exposed would show up. But then everybody showed up if the people who did not get exposed would get paid. Then everybody who got exposed actually showed up. Those people were hiding before. That is a uniquely Nigerian solution. And I think we're going to find something similar in this COVID.
Thank you very much. And so my job now is just to conclude by really giving my own heartfelt thanks on behalf of, the organizers, as well as all the, the public who have dialed in today, to the panelists who themselves are healthcare leaders at the front line of this disease at this time in this country. And we started the conversation, I opened the conversation around the constraints of resources, the resource constraints that we face as a country in healthcare. But yet, in spite of it, you are all doing what you are doing. And we are getting the results, and we are getting solutions, as you said, to really being able to deal with the pandemic here. Having been a healthcare manager of resources, of meager resources myself for many years, I appreciate just how difficult this task is. And therefore, I can only repeat again my thanks on behalf of everyone who's been here and what you're doing. So thank you very much, sirs, for your contributions tonight and your contributions at the front line. And can I also just say thank you very much to all the public who have dialed in and who have stayed on for this amount of time. I'm mindful that it is almost time to break fast, so I will now move very quickly just to say that we are concluding this very distinguished panel. and happy and thankful for your candid participation. I believe your questions will be cataloged and we will still share them because we do have a lot of questions still coming in. But let me also on this note also just thank Emmanuel Chapel and Professor Ajayi and the team for putting this series together, and to remind everyone that there will be the next diet in the series, which will come up next Friday. Another outstanding panel will be discussing the topic of biosecurity, national emergencies, and COVID-19 disruption. So we really look forward to again joining and tuning in for that discussion. On this note, to say thank you very much all and good night. Thank you very much.
Thank you.
Thank you.